Hello everyone, I am Dr. Rupesh Kard and welcome to another episode of Medical Detective. Today we are discussing a guideline that may change how you see a very familiar patient, the patient with obesity, diabetes, hypertension, abnormal lipids and early kidney dysfunction. Previously we often managed each problem separately. The 2026 CKM or cardiovascular kidney metabolic guideline asks us to see one connected system, the heart, kidneys and metabolism influencing one another. So let us begin with an apparently routine patient. A 48-year-old South Asian man attends for a routine diabetes follow-up. His BMI is 29 kg per square meter. Waist circumference is 101 centimeters. Blood pressure is 146/92. His HbA1c is 7.8% and triglycerides are 238 mg per deciliter. His eGFR is 68 ml per minute per 1.73 square meters, which may not immediately alarm us, but his urine albumin to creatinine ratio is 145 mg per gram. He has no chest pain and no dyspnea. How would you describe him? Is this simply diabetes with hypertension, or is there a larger syndrome connecting these findings? Keep your answer in mind. We will stage him shortly. CKM syndrome is not merely a new label, it is a new clinical lens. Excess or dysfunctional adipose tissue promotes insulin resistance, inflammation, hypertension, and abnormal lipids. These metabolic abnormalities accelerate both chronic kidney disease and cardiovascular disease. Kidney disease then amplifies cardiovascular risk through volume and neurohormonal disturbances, inflammation, anemia, and vascular disease. When heart failure or atherosclerotic disease develops, kidney function and metabolic health may worsen further. So these are not three unrelated comorbidities. They form a biological feedback loop. The 2026 guideline is the first full clinical practice guideline organized around the cardiovascular kidney metabolic axis. 4 changes matter most. First, it uses a stage 0 to stage 4 continuum, allowing intervention before symptomatic cardiovascular disease appears. Second, it places the PREVENT equations at the center of risk assessment. PREVENT estimates atherosclerotic cardiovascular disease, heart failure, and total cardiovascular disease risk. Third, kidney risk is assessed using both eGFR and UACR, which is urine albumin to creatinine ratio. A reasonable eGFR does not make albuminuria less important or unimportant. Fourth, the guideline emphasizes on coordinated care. Weight, blood pressure, lipids, diabetes, kidney protection, and cardiovascular prevention should be treated as parts of one plan. Let us simplify the stages. Stage 0 means no CKM risk factors. The goal is to preserve cardiovascular health. Stage 1 includes excess or dysfunctional adiposity or prediabetes without the additional metabolic risk factors, CKD or cardiovascular disease that define later stages. Stage 2 includes one or more metabolic risk factors such as hypertension, abnormal lipids, diabetes or metabolic syndrome, and or chronic kidney disease, but without subclinical or clinical cardiovascular disease. Stage 3 is a silent transition. The patient has subclinical cardiovascular disease, pre-heart failure, very high risk CKD, or a predicted 10-year total cardiovascular disease risk of at least 20% using PREVENT equations. Stage 4 means clinical cardiovascular disease such as coronary artery disease, heart failure, stroke, peripheral arterial disease, or atrial fibrillation. This is present with metabolic risk factors, excess adiposity, or kidney disease. Stage 4A is without kidney failure, and stage 4B includes kidney failure. So the stage tells us how intensively to evaluate, prevent, and treat. Now return to our patient. He has central adiposity, hypertension, hypertriglyceridemia, type 2 diabetes, and albuminuria with a UACR of 145 mg per gram. At this point, he has no demonstrated subclinical or clinical cardiovascular disease. Therefore, he fits CKM Stage 2. The important twist is that his eGFR of 68 could easily be described as only mildly reduced, but the normal UACR reveals kidney damage and changes both his renal and cardiovascular disease risk. This visit should not end after reviewing HbA1c and serum creatinine. The urine results change the seriousness of the consultation. A CKM assessment is broader than checking glucose and creatinine. Measure weight, BMI, waist circumference, and weight trend. Assess blood pressure, glucose or HbA1c and a lipid profile. For the kidneys, obtain both eGFR and UACR. eGFR estimates filtration, UACR detects albumin leakage and may reveal kidney and vascular injury even when the filtration is relatively preserved. When CKD is present, combine GFR and albuminuria categories using the KD risk grid. Then assess cardiovascular risk through symptoms, examination, prevent equation, and selected tests. ECG is often practical. Coronary calcium, natriuretic peptides, troponin, or echo should be used when risk or clinical findings justify them. This is not routine for every patient. The practical message is simple. Do not forget urine albumin creatinine ratio. PREVENT stands for predicting risk of cardiovascular disease events. For adults aged 30 to 79 years without known cardiovascular disease, it estimates 10-year risk and where appropriate 30-year risk. The longer estimate is useful in younger adults whose short-term risk may appear low despite substantial lifetime risk. PREVENT can estimate total cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure risk. Its base equations include kidney and metabolic information such as BMI and eGFR, while add-on models may incorporate UACR and HbA1c. A predicted 10-year total CVD risk of 20% or more is one criterion for CKM Stage 3. For Nepali and other South Asian patients, interpret the exact percentage cautiously because PREVENT was developed mainly in US cohorts. Use it as a structured decision and communication tool combined with ancestry, family history, local context, and clinical judgment. The calculated percentage is not the whole patient. Risk enhancers may justify more intensive prevention when the estimate is borderline or uncertain. Examples include family history of premature cardiovascular disease, diabetes or kidney failure, South Asian ancestry, chronic inflammatory conditions such as SLE or HIV, and albuminuria. Social factors also alter risk and treatment success. Financial strain, food insecurity, difficulty reaching follow-up, and limited medication access directly influence outcomes. So a useful formula is CKM Stage plus PREVENT risk plus individual risk enhancers. Together, these produce a more meaningful assessment than a single number. CKM management has 4 major levers. First, address weight and dysfunctional adiposity. Second, control blood pressure and lipids according to total risk. Third, choose diabetes therapy for cardiovascular and kidney protection, not only HbA1c reduction. Fourth, protect the kidneys and appropriate use of renin-angiotensin system inhibitors, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, and GLP-1 based therapy. These interventions should not be delayed one after another over many months. The organs are interacting simultaneously, so treatment should also be integrated. Lifestyle remains foundational, but it should be a real prescription rather than a vague instruction to lose weight. Discuss dietary quality and energy balance, sodium intake, physical activity, resistance training, sleep, tobacco avoidance, and self-monitoring of weight and waist circumference. The guideline treats adiposity as a biological driver of CKM progression, not a cosmetic problem or failure of willpower. In selected patients, anti-obesity pharmacotherapy, including GLP-1 based treatment, may be appropriate depending on obesity, diabetes, cardiovascular and kidney risk, contraindications, tolerability, availability, and cost. Metabolic or bariatric surgery may benefit properly selected patients. In Nepal, feasibility matters. The plan should be evidence-based, but also financially realistic and acceptable to the patient. In CKM syndrome, selecting a glucose-lowering drug becomes an organ protection decision. Asked, does the patient have CKD or albuminuria, heart failure or high heart failure risk? Is obesity a major driver? Is ASCVD or high CVD risk present? Can the patient afford and tolerate the treatment? An SGLT2 inhibitor is often prioritized when CKD, albuminuria or heart failure risk is present, provided kidney function and other clinical factors allow it. A GLP-1 based therapy may be valuable when obesity, type 2 diabetes, cardiovascular risk or kidney risk is prominent. Metformin remains useful and affordable for many patients, but it may not provide the cardinal protection that a high-risk CKM patient needs. A satisfactory HbA1c does not automatically mean CKM risk is adequately treated. Albuminuria is both a kidney marker and a cardiovascular risk signal. For hypertension with albuminuria, an SC inhibitor or ARB is generally preferred when tolerated with monitoring of creatinine and potassium. For CKD with type 2 diabetes or CKD with albuminuria, an SGLT2 inhibitor can provide kidney and cardiovascular protection in appropriate patients. If type 2 diabetes and CKD are present and UACR remains at least 30 mg per gram despite optimized RAS blockade and SGLT2 inhibitor therapy, a non-steroidal MRA may be added when potassium and kidney functions permit. GLP-1 based therapy may provide additional benefit when obesity, diabetes, albuminuria or high cardiovascular risk remains important. This is a simplified framework. Real prescribing requires attention to eGFR, potassium, volume status, adverse effects, contraindications, interactions, and follow-up. Blood pressure and lipid treatment should reflect total risk and expected benefit, not isolated numbers. Measure blood pressure accurately, confirm persistent elevation, and address sodium intake, weight, activity, sleep, and adherence. Albuminuria often gives RAS inhibition a special role. Stage 2 or Stage 3 CKM commonly prompts a serious statin discussion with intensity based on age, diabetes, CKD, predicted risk, risk enhancers, tolerance, and lipid guidelines. High triglycerides are a metabolic warning sign, but simply lowering TG is not the whole objective. The real goal is to reduce MI, stroke, heart failure, and kidney disease progression. Now let us add a twist to our case. Our patient still has no chest pain and no dyspnea. However, his ECG shows LVH with a strain pattern. NT-proBNP is 165 pg per milliliter. Echocardiography shows concentric LVH and diastolic dysfunction. His prevent CVD 10-year risk is also high. Now he is no longer simply stage 2. An NT-proBNP of 165 is above guidelines pre-heart failure biomarker threshold of 125 pg per milliliter in a patient without established clinical heart failure. Relevant structural or functional abnormalities on echo may also identify pre-heart failure. And if his predicted 10-year cardiovascular risk is at least 20%, that independently meets a stage 3 criterion. Therefore, he is a CKM stage 3. CKM risk factors with subclinical cardiovascular disease, pre-heart failure, very high risk CKD, or an equivalent predicted risk. Absence of symptoms does not mean absence of cardiovascular disease. Stage 4 begins when clinical cardiovascular disease appears. This includes coronary heart disease, symptomatic heart failure, stroke, peripheral arterial disease, or atrial fibrillation in a patient who has excess adiposity, metabolic risk factors, or kidney disease. Stage 4A means clinical cardiovascular disease without kidney failure. Stage 4B means clinical cardiovascular disease with kidney failure. At this stage, we are practicing integrated secondary prevention, often with complex medication, monitoring, and coordination needs. Here is a 5-step workflow for a busy OPD. Step 1, identify. Measure BMI or waist, blood pressure, glucose or HbA1c, lipids, eGFR, and UACR. Step 2, stage. Decide whether the patient is stage 0, 1, 2, 3, or 4, and ask whether subclinical or clinical cardiovascular disease is present. Step 3, quantify. Use prevent where applicable and add individual risk enhancers. Step 4, treat. Address weight, blood pressure, lipids, diabetes, kidney protection, smoking, and physical activity together. Step 5, coordinate, decide who will follow the patient, when laboratory tests will be repeated, which referrals are necessary, and whether the plan is understandable and affordable. CKM care does not always require a new clinic. It requires a consistent system. What might a coordinated plan look like for our patient? Create a realistic weight and waist reduction plan, confirm his blood pressure and optimize an ACE inhibitor or ARB because he has hypertension with albuminuria, while monitoring for creatinine and potassium. Discuss appropriate statin therapy according to diabetes, kidney markers, and total CVD risk. Review his diabetes regimen because he has albuminuria and high cardiorenal risk. Consider an SGLT2 inhibitor if there is no contraindication and it is affordable. Consider GLP-1 based therapy if obesity and high cardiovascular risk remains major priorities. If albuminuria persists despite optimized RAS inhibition and SGLT2 inhibitor therapy and potassium is suitable, consider non-steroidal MRA. Repeat blood pressure, eGFR, UACR, potassium, weight and glycemic measures after treatment changes. This is coordinated thinking, not a universal prescription. Now, the main question is, how can we apply CKM care in Nepal without making every OPD visit complicated or unaffordable? Start with tests that change management today: BMI or waist, blood pressure, glucose or HbA1c, lipids, creatinine with eGFR and UACR. Then stage the patient, estimate risk when possible, and actively look for albuminuria and heart failure symptoms. Escalate evaluation when UACR is high, eGFR is falling, BP is resistant, dyspnea or congestion is present, or predicted risk is very high. Do not order every biomarker or scan for every patient. Use risk to select further testing. Prevent should support clinical judgment and not replace it. Now we discuss 5 mistakes that make CKM syndrome invisible. 1. Treating HbA1c repeatedly but never checking UACR. 2. Calling CKD mild because creatinine looks near normal without combining eGFR and albuminuria. 3. Ignoring waist circumference and dysfunctional adiposity. 4. Waiting for chest pain, dyspnea, stroke or heart failure before discussing cardiovascular risk. 5. Adding one drug at a time without deciding what complete heart, kidney, metabolic plan should achieve. Now, this is a Viva question for you. Which inexpensive test most changed the staging and urgency in our opening patient? The answer is UACR. Let us summarize CKM syndrome now. Cardiovascular, kidney and metabolic risks are biologically connected and should not be treated as unrelated comorbidities. Stage the patient from 0 to 4. Stage 3 is the silent transition where subclinical cardiovascular disease, pre-heart failure, very high risk CKD or very high predicted risk is present before overt symptoms. Do not miss albuminuria. Use UACR together with eGFR. Use prevent equations as a structured risk and treatment tool where applicable, while recognizing limitations in local calibration. Treat adiposity, blood pressure, lipids, diabetes and kidney risk together. Our patient was not simply diabetic and hypertensive. He was a CKM patient whose kidneys and cardiovascular system were already signaling risk. We simply needed to recognize the language. Before you leave, answer this in the comments. A patient has obesity, type 2 diabetes, hypertension and UACR of 145 mg per gram, but no subclinical or clinical cardiovascular disease. Which CKM stage is this? These are my references. Thank you for watching. See you in the next video.